Okay, very nice. Okay. Ok. Bueno, pues buenas tardes a todos. Estamos en un webinario más de nuestra Asociación Mexicana de Ultrasonografía, Crítica y Urgencias. Estamos en esta ocasión muy contentos porque tenemos a varios invitados muy relevantes, muy importantes en este webinario. Estamos transmitiendo desde la ciudad de Monterrey, Nuevo León, para todo México, para toda Latinoamérica. Les damos la bienvenida, sobre todo a nuestros amigos en Latinoamérica, en todo lo que es Colombia, Ecuador, Bolivia. Tenemos muchos seguidores en Argentina, en Uruguay, en Brasil. Y pues bueno, les damos la bienvenida también desde luego a toda la gente que nos sigue en nuestra página en nuestro país, aquí en México. Y pues bueno, en esta ocasión tenemos ya el último webinario de esta temporada 3 y la última del año. Cerramos con broche de oro teniendo a un gran invitado internacional y desde luego a dos colegas locales de aquí de nuestro país, también muy importantes profesores de nuestro grupo, de nuestra asociación, en la terapia intensiva de nuestro Hospital Civil de Guadalajara. Así que sean ustedes bienvenidos. Voy primero a presentarles a nuestros profesores locales, al doctor Julio Mijangos, quien es profesor desde hace muchos años en la ciudad de Guadalajara, en el Hospital Civil de Guadalajara. Él, bueno, aparte también de ser parte de la mesa directiva del Colegio Mexicano de Medicina Crítica, bueno, pues es profesor de este grupo tan entusiasta de médicos en la unidad de cuidados intensivos del Hospital Civil, que es uno de los primeros grupos que incorporó el ultrasonido en el punto de atención, el ultrasonido crítico. Son de las primeras terapias intensivas que utilizan esta gran herramienta, y sobre todo ellos han profundizado mucho en lo que es el Doppler transcranial gracias al doctor Julio Mijangos, que es un sobresaliente profesor a nivel nacional. ¿Cómo estás, Julio? Bienvenido.
Buenas tardes, Juan Antonio. Pues todo bien. La verdad es que agradecido con la invitación y esperemos aportar granito de arena, ¿no?
Claro, claro. Sí, muchas gracias, Julio, a ti por aceptar esta invitación. Igualmente, Arnulfo, al doctor Arnulfo López es parte de nuestro grupo. Él también ha sido colaborador en lo que es la Asociación Mexicana de Ultrasonografía, Crítica y Urgencias. De hecho, él es nuestro presidente pasado. Y pues bueno, estamos también muy contentos. Él es también, como les comento, parte de los profesores que imparten la ultrasonografía crítica y especialmente el ultrasonido Doppler transcranial en esta fabulosa unidad de cuidados intensivos en el Hospital Civil de Guadalajara. ¿Cómo estás, Arnulfo? Bienvenido.
¿Qué tal a todos? Pues muy contento de participar en este webinario y pues muchas gracias al doctor Danilo por participar y pues gracias a todos por conectarse.
Perfecto, Arnulfo, muchas gracias a ti. Y bueno, les presento al doctor Danilo Cardim, quien, como les comentaba, es un médico muy sobresaliente a nivel mundial en el tema del neuromonitoreo y especialmente sobre el monitoreo no invasivo y sobre el monitoreo Doppler transcranial. Él tiene muchos artículos, ha participado en diferentes foros sobre lo que es el neuromonitoreo. Como ustedes seguramente podrán ver, la literatura es muy vasta sobre el monitoreo Doppler transcranial que tiene el doctor Danilo. Él ha sido pues alumno de grandes profesores a nivel mundial, entre ellos la doctora Chiara Roba, quien ha sido también parte de este espacio, y pues a quien le mandamos también un afectuoso saludo desde aquí, desde México. El doctor Danilo, como les comento, en este momento está trabajando en la ciudad de Texas, pero formado desde luego en la división de neurocirugía y en el departamento de clínico de neurociencias en la ciudad de Cambridge. Así que bienvenido, Danilo. Thank you so much for accepting this invitation. We are very excited. I'm very happy. Let's get started with your conference, Danilo. Thank you so much.
Absolutely. Thank you very much, Dr. Calderon, for the invitation, and it's a great pleasure for me to present some of my works during my PhD in Cambridge, which were mostly based on ultrasound-based non-invasive measures of intracranial pressure, and my focus was mostly on transcranial Doppler ultrasonography. So I'm currently not based in Cambridge anymore. I'm based in Dallas, Texas, working for University of Texas Southwestern Medical Center. But today I will present my PhD works developed at the University of Cambridge. So we know that in neurocritical care monitoring, we have vast sorts of different types of monitorings, including intracranial pressure, microdialysis, brain tissue oxygenation, and everything. But one of the main problems in neurocritical care, and mostly regarding research, is how to integrate all of these information and obtain useful information to the prognosis and outcome to the patients. So in Cambridge, at the Brain Physics Laboratory, over the past 25 years, Dr. Marek Chosnik and Dr. Peter Smielewski, they have developed this software called ISM+, which stands for Intensive Care Monitor, which is basically a software that can harvest, collect all data coming from the bedside monitors connected to the patients. And most of the applications so far have been in neurocritical care, specifically traumatic brain injury, subarachnoid hemorrhage, and hydrocephalus. But obviously, this software, once installed in the computer and the computer connected to the bedside monitor, can be applied in all sorts of intensive care units. And because of the integration allowed by the software, we can perform several types of calculations, mathematical transformations that give us many physiological parameters, for example, cerebral circulation, and what I'm going to talk today, the non-invasive estimation of intracranial pressure based on mathematical models. So we know that intracranial pressure is mostly consists of four components inside the intracranial cavity. The first is the arterial component, which is mostly related to the inflow and volume of arterial blood to the intracranial space. The second is related to venous blood, specifically the venous blood outflow. Also the cerebrospinal fluid circulation in the subarachnoid spaces. And finally, regarding the brain parenchyma. So early monitoring, well, as we know, at the current state of development, most of the clinically used ICP monitoring methods, they're invasive. And the early findings regarding ICP monitor, they date from the 1950s by Guillaume and Janie. So they first published this paper, Continuous Intracranial Manometry, Physiopathological and Clinical Significance of the Method. So as we can see here in this picture, they report the ICP values and trends over time along 1 hour. And we can clearly see patterns, for example, plateau waves of intracranial pressure, these massive increases in intracranial pressure that are sustained for some period of time. And then, well, the topic of intracranial pressure continued with Lundberg regarding the continuous recording and control of ventricular pressure in neurosurgical practice. And Lundberg was one of the first researchers to describe the different types of waves in intracranial pressure, for example, the plateau waves, the B waves, and etc. So as we know, currently the current clinically available ICP monitor methods, they're all invasive and mostly consist of 4 different types. So the first one, as we can see here in this picture, is the intraventricular method. So this is considered the gold standard because not only provides the continuous monitoring of intracranial pressure, but also allows, once there is an external ventricular drainage connected to the cannula, to drain excessive cerebrospinal fluid if the pressure is increased. and one of the ways to alleviate cases of intracranial hypertension. Also, one of the most used methods is the intraparenchymal, the number 2, which is a microtransducer, a piezoelectrical based sensor that once in contact with the cortex around 5 to 6 centimeters inside the cranial cavity can monitor intracranial pressure over time. And 3 and 4 are less common, are the epidural methods. So as we know, all of these methods are invasive and consequently very restrictive and mostly applied nowadays to very critical conditions such as traumatic brain injury, in which we do have to know the values of intracranial pressure to control cerebral perfusion pressure and provide adequate cerebral blood flow to these patients. So, given the limitations of these methods over, I would say, the last 20, 30 years, there have been reported many attempts to monitor intracranial pressure non-invasively based on many different methods. So if we do literature research at the moment, at PubMed, for example, we can find at least 5 categories of non-invasive methods. For example, the methods based on audiological findings, methods based on ophthalmological findings, ultrasound findings, methods based mostly on the pulsatility of the arterial blood pressure, and also more advanced mathematical models associating changes in arterial blood pressure to changes in cerebral blood flow velocity obtained with transcranial Doppler. So we can also subdivide these methods into 3 other categories based on these columns here, whether they provide absolute values of intracranial pressure, for example, in millimeters of mercury, whether they are calibration free, or whether they provide continuous monitoring of this parameter. So regarding our topic in this presentation, ultrasound itself, I'll just present some brief facts that I believe most of you will be familiar with, since I'm speaking here with a group of ultrasonologists. We know that ultrasound waves travel at constant speed around 1,000 meters per second in biological tissues. We also know that ultrasound is reflected at the boundary of the 2 media, for example, the media wherein we are insulated and the internal media in the body. Ultrasound is also backscattered in heterogeneous tissues, and the higher ultrasound frequencies and the higher, we know that the higher the ultrasound frequency, the higher the attenuation and the hollower the penetration depth. So, for example, transcranial Doppler ultrasonography uses mostly 2 megahertz probe that is suitable to insulate arteries within 15 centimeters to 60 centimeters inside the brain. So regarding the Doppler principle in sonography, as I said before, mostly for the assessment of non-invasive intracranial pressure, we will use a 2 megahertz probe to insulate the vessels at the circle of Willis. Specifically, in my case, in my works, the middle cerebral artery. And the principle of the Doppler in ultrasound is that when we emit the mechanical wave coming from the probe at a certain frequency, in this case 2 megahertz, once it reaches the vessels and the red cells, we have, well, the signals, they return to the probe at a different frequency, and then we have the frequency shift that represents, in this case, a direct relationship to the velocities, to the velocity of the red cells. And as we know, the faster these objects are circulating inside our vessel, the higher the Doppler shift and the higher the velocity we will obtain. So for transcranial Doppler ultrasonography of the middle cerebral artery, we mostly use the transtemporal window at which we can find the middle cerebral artery within the depths of 50 to 70 millimeters inside the intracranial cavity. And for example, this is just one picture that denotes how we observe these recordings using the most conventional ultrasound transcranial Doppler machines. So on the bottom panel, we have the envelope of the waveform. So we can see the peak systolic and diastolic of the waveform inside the middle cerebral artery. And the upper panel is what's called the M mode, which stands for motion mode ultrasound, in which we can observe the different depths of insonation. For example, here we can see that at around 45 to 46 millimeters, we obtain the signal from the middle cerebral artery, but also we can find other even branches, different branches from the middle cerebral artery around 50 to 65, and also posterior cerebral artery and all the other branches of the circle of Willis. So now regarding TCD applications. So TCD has been applied mostly to assess cerebral hemodynamics in all sorts. So conditions that TCD have been mostly reported are in traumatic brain injury, TBI, hydrocephalus, stroke, arterial stenosis and occlusion, brain death to detect brain death, and cerebral infections. But also given the possibility to integrate signals in neurocritical care, it has also been possible to obtain indices of cerebral turbulation, for example. Indices correlating changes in arterial blood pressure being transmitted to cerebral blood flow. And also, as a topic of this presentation, mathematical models to estimate non-invasive intracranial pressure. So let's start talking about then the mathematical models that can derive ICP non-invasively using ultrasound. So I will talk about mostly methods that have been the topic of my PhD thesis, and also give some examples based on previous publications of my works. So the first method is called, it's a method based on a black box system. So basically a black box system is a transfer function. So transfer function is a signal processing technique that basically applies the Fourier transform in a time series signal, basically decomposing the signals into different frequencies. So for the black box system and overall to any transfer function analysis, we have a system with an input. In our case is the arterial blood pressure, and we have an output, which in our case is the non-invasive intracranial pressure. So between these two input and output, we know that we have the cerebral blood flow velocity assessed with transcranial Doppler. So basically what this method, how this method is constructed is that we first establish a transfer function between arterial blood pressure and cerebral blood flow velocity, which is here is called this non-transfer function. And then we input into this mathematical model certain characteristics called here modification characteristics. That could be, for example, different parameters obtained with transcranial Doppler that are very specific to changes in intracranial pressure, for example. We can input, for example, the pulsatility index coming from transcranial Doppler. We can input the different components of the cerebral blood flow velocity waveform, for example, the systolic peak or the end diastolic. and also the mean cerebral blood flow velocity, parameters that will contribute to the model in order to obtain more to obtain characteristics that reflect changes in intracranial pressure better. So then, finally, we have signals from arterial blood pressure, cerebral blood flow velocity, into an unknown transfer function that contains all these characteristics that gives us the non-invasive intracranial pressure. In this case, for this method, we obtain even waveform for each heartbeat, and also the absolute values for intracranial pressure in millimeters of mercury. The second method is possibly the most known method in the literature, which is the one based on the pulsatility index of the cerebral blood flow velocity waveform obtained with transcranial Doppler. So we know that the pulsatility index, mostly regarding the Gaussian pulsatility index, is based on the difference between systolic peak and diastolic end values divided by the mean cerebral blood flow velocity. And this formula, non-invasive ICP equals 4.47 times PI plus 12.68 millimeters of mercury, is derived from our cohort of traumatic brain injury patients in Cambridge University, in which we have collected over 300 patients, and then we created a mathematical model between changes in pulsatility index and changes in ICP, as we can see here, as we can observe in this plot. So basically, as we can see, the pulsatility index presents a linear relationship with ICP. But also this method has been confronted in the literature regarding its non-specificity to changes in intracranial pressure. And indeed, the pulsatility index is not overall a reliable predictor of changes in intracranial pressure, because the pulsatility index is subject to many physiological confounders. For example, the level or the degree of pulsatility in arterial blood pressure, and also the levels of carbon dioxide and cerebral arterial blood, and other factors that can affect the pulsatility index. So overall, pulsatility index, as has been described previously in the early 2000s, are not overall a very reliable predictor of changes in intracranial pressure. The third method is based on the diastolic components of the cerebral blood flow velocity. It's called the diastolic cerebral blood flow velocity formula. So primarily, this method was developed to estimate the non-invasive cerebral perfusion pressure based on a ratio of arterial blood pressure times this ratio of flow velocity diastolic divided by flow velocity mean, accounting this factor of 14 millimeters of mercury that are also based on our cohort of traumatic brain injury patients at Cambridge University. So, as one of the premises of this method is that, for example, when we have changes in intracranial pressure and cerebral perfusion pressure, as we can see here in this figure, we have clear changes in diastolic flow velocity as well, and mostly the systolic flow, cerebral blood flow velocity is maintained constant. So in this case, for increases or decreases over changes in intracranial pressure and cerebral perfusion pressure, the most sensitive parameter will be the diastolic cerebral blood flow velocity. That's why we have created this ratio to try estimate the non-invasive cerebral perfusion pressure. But based on the assumption that intracranial pressure is the difference between arterial blood pressure and cerebral perfusion pressure, and since we know in most cases the mean values of arterial blood pressure, we can also estimate the non-invasive intracranial pressure based on this basic assumption. The fourth method is a method based on this concept of critical closing pressure, and also this method has been, well, critical closing pressure has also been named in the literature as zero flow pressure, but basically it denotes the lower limits of arterial blood pressure in which the small cerebrovascular circulation are prone to collapse due to critically reduced transmural pressure. And for example, as we can see here, during increases in ICP, in this case, during a plateau wave of intracranial pressure in which we have this sustained increases in ICP, we can observe that critical closing pressure also increases. And then the difference between critical closing pressure and the arterial blood pressure will be diminished, and then resulting in diminished wall tension, or that is, the ability of the vessels to respond to this increasing pressure will be diminished, as we can see here. So this is a more complex formula that has also been derived primarily to obtain the non-invasive cerebral perfusion pressure, and one of the most, one of the main parameters that we need to calculate to obtain critical closing pressure are the cerebrovascular resistance, the compliance of the cerebral arterial bed, and also the heart rate. And while this formula has been described in the literature many times, and with also different approaches, and for this case we have used the approach developed by our laboratory in Cambridge, and also based on the assumption that ICP equals the difference between arterial blood pressure and CPP, we can derive the non-invasive intracranial pressure. So regarding the clinical applications of these mathematical-based models. So during my PhD, I have worked mostly with traumatic brain injury and also hydrocephalus patients. So these are the two clinical conditions that I will present to you today as examples. So traumatic brain injury, as we know, is defined as an alteration in brain function or any other evidence of brain pathology caused by an external force. For example, as we know, car accidents are the most common cause of TBI, but also domestic falls and assaults. And the neurological damage from TBI may not occur specifically at the moment of the impact, but it evolves over time in the ensuing days and hours as a consequence of the secondary injuries caused mostly by decreases in cerebral blood flow. And improved outcomes are obtained when these secondary insults resulting in diminished cerebral perfusion pressure to the brain are prevented or responded to treatment according to the Brain Trauma Foundation. So that's why it is very important to monitor cerebral blood flow in the neurocritical care unit to prevent these sudden changes in cerebral circulation. So this first work was published in Journal of Neurotrauma, in which we compared these 4 methods based on mathematical models in 40 prospectively collected traumatic brain injury patients in our units at Addenbrooke's Hospital in Cambridge. And then The intention was to observe the correlation coefficient. These methods presented with invasive intracranial pressure at a first attempt, and also to determine the agreement between all of these methods to the absolute values of intracranial pressure, and also observe whether these methods would be able to demonstrate their ability to track changes in intracranial pressure over time, independently of the inaccuracy in absolute values. So first of all, regarding the correlation coefficients, we observed that these methods generally, let's say, the black box model, the flow velocity diastolic model, and the critical closing pressure model, they will present moderate correlations with intracranial pressure measured invasively, in this case using the intraparenchymal probes. And the least accurate method here was the pulsatility index method that only showed correlation coefficient of 0.15. All of the others around 0.3 to 0.4 presenting significant correlations. Regarding the agreement between these methods, they were determined using the Blend-Altman analysis. So overall, they will present an agreement of plus minus 10 millimeters of mercury, being the non-invasive method based on diastolic flow velocity, the one presenting the highest confidence interval for agreement, around 15 millimeters of mercury. And also this, these figures, they illustrate the ability of the methods to track these changes in intracranial pressure over time. In this case, not looking specifically at the values in millimeters of mercury. So here, for example, at the upper panel, we have this increase in ICP over time that equals a delta above 10 millimeters of mercury. And what we wanted to observe for the non-invasive methods is that they would present a similar pattern of increases and decreases. So here, the first panel on the left, we have the plots for the black box transfer function method, in which we observe this correlation over time of 0.6. The diastolic flow velocity method presented a correlation of 0.71. As we see here, we can clearly see an improvement in the shape of this increase over time. The critical closing pressure method and the pulsatility index method, they presented the same ability of detecting this specific change over time. And then, as we can see here, we can clearly see increases, patterns of increase and decrease in intracranial pressure, but then not considering the agreements in absolute values here. So as if we were to compare, for example, the black box model in this case presented, let's say, from 14 millimeters of mercury to 28, so a difference of around 14. And then if we were to compare here, the invasive method from 5 millimeters of mercury to around 23, we would have 18. So they are not, there is an intrinsic error associated with obtaining absolute values, as we observed here from the Blend-Altman analysis. And also, another example of the black box model trying to detect changes in intracranial pressure over time. As we can see here, we have an example of a vasogenic wave of intracranial pressure. In this case, it's a plateau wave of intracranial pressure, in which we observe these massive increases in intracranial pressure that are sustained over time, and then resolving to a decrease at a later stage. As we can see here, from the black box model, we can also obtain the waveform. So here, as we see, we can even obtain a resolution to detect the different peaks in intracranial pressure from this method. And also, as intracranial pressure increases, we observe this increase in the amplitude of the wave that is also reflected in the black box model. Another case, well, in this example, comparing all the four mathematical-based models. At the upper panel, we have invasively measured ICP. In all cases that I'm presenting here, we have collected data using the intraparenchymal probes. And then we can see a consecutive monitoring, including 3 plateau waves of intracranial pressure, that all of the methods were able to detect accurately with the correlation coefficient over time above 0.8, so quite reliably, despite the potential disagreements concerning the absolute values of intracranial pressure changes. And the second clinical condition that I would like to give examples on using these mathematical model non-invasive ICP methods is regarding hydrocephalus. So hydrocephalus is, well, a textbook definition is considered the accumulation of cerebrospinal fluid in the intracranial cavity, but this is far more complex disorder than just related to the accumulation of cerebrospinal fluid in the intracranial space. So it is also related to also changes in blood flow that well, interplay with impaired cerebrospinal fluid circulation, leading to the clinical symptoms of hydrocephalus. So in this case here is the same set of comparisons in which we wanted to assess these 4 mathematical-based models to estimate changes in intracranial pressure. But in this case, in a set of patients with hydrocephalus undergoing what is called cerebrospinal fluid infusion tests. So basically what these tests depict is that we have a baseline in which we're not doing any intervention. So basically, in this case, intracranial pressure is being monitored using lumbar puncture. So we monitor intracranial pressure for a baseline period, and after this baseline period, we start to infuse a mock cerebrospinal fluid solution into the spinal canal in order to increase intracranial pressure. So the overall objective of these cerebrospinal infusion tests is to test the resistance to CSF outflow in these patients that have been related to the diagnosis of normal pressure hydrocephalus. So as we see, we have this gradual increase in intracranial pressure until we reach a certain plateau. So we wanted to observe these changes in intracranial pressure over time for all of these methods. So as we see here, we can reliably observe that these methods, they can detect these changes over time with considerably high correlation coefficient. But for certain cases, we observe that these correlations are not that great, and even in some cases, they are a negative association between changes in ICP and changes in the non-invasive ICP. So for these hydrocephalus patients undergoing cerebrospinal infusion tests, what's going on? Like, in certain cases, we have a very high correlation. In certain cases, we have very low correlations. So in this case here, we can observe that during the cerebrospinal infusion, we had a spontaneous vasogenic wave of intracranial pressure generated in one patient. And we can observe the same pattern of increases and decreases using the non-invasive methods. So in cerebrospinal fluid tests, the component of intracranial pressure driving the increases in intracranial pressure is the increased circulation of cerebrospinal fluid volume. But in the case of spontaneous plateau waves of intracranial pressure, they are vasogenic waves, meaning, for example, we have vasodilation, and with vasodilation, we have increased volume of arterial blood occupying the intracranial space. So we have a greater output of blood causing this increase in intracranial pressure. So as we know, transcranial Doppler is mostly devoted to assessing changes in the vasculature. So in this case here, we observed that the methods based on transcranial Doppler, they were able to observe these changes in cerebral blood flow volume in the intracranial space. So in another cases, for example, in which we didn't have this massive increases in intracranial pressure based on vasogenic changes, for example, just relying on increased volume of CSF, cerebrospinal fluid circulation in the intracranial space, we had less apparent correlations over time for these methods. So, which brings us the question that would be these methods based, the non-invasive ICP methods based on transcranial Doppler more specific to changes related to increases or decreases in cerebral blood volume, other than other components related to increases in intracranial pressure, for example, CSF circulation? The answer is yes, because with transcranial Doppler, we are mostly assessing the cerebral blood flow velocity inside the arteries. We're not considering the overall picture that denotes the increases in intracranial pressure that also might consider increases in cerebral spinal fluid circulation. And another example to depict this intrinsic ability of the transcranial Doppler methods to assess changes in blood volume is that, for example, in this case, also a patient undergoing cerebrospinal fluid infusion, we had during infusion what is called B waves. So B waves are these periodic increases and decreases in blood volume to the brain. And here we can observe this clearly with the invasive method and also with the non-invasive method. So also, again, denoting this ability of the non-invasive methods to detect changes that are greatly related to cerebral blood flow volume, other than other components of increase in intracranial pressure, as for example, increased volume of cerebral spinal fluid circulation. So, to finish this presentation, well, it's wise to state some of the challenges regarding the assessment of non-invasive intracranial pressure with transcranial Doppler ultrasonography. We know that transcranial Doppler ultrasonography is a quite challenging technique, mostly regarding the monitoring over time of cerebral blood flow velocity. in neurocritical care specifically because these patients, they are undergoing nursing intervention and medical interventions almost all the time. For example, changes in bed position, going to MRI, drug interventions of all sorts. These interventions, they will over time interfere in the accuracy of the transcranial Doppler assessment. We also know the intrinsic disadvantages of the state-of-the-art transcranial Doppler machines that, for example, are not does not present, well, these machines do not present good signal resolution, and sometimes there's also the disadvantage of the absence of a proper insonation window to assess the circulation in the middle cerebral artery. And well, also again, the same as in the same topic, all the current TCD technologies, they don't allow continuous TCD sessions because well, we have external sensors attached to the patients that are being influenced by external forces as nursing interventions, for example. So we cannot perform longer TCD monitoring sessions in these patients. So for example, we cannot observe what is going on with specific cases, for example, whether these patients are presenting vasogenic waves of intracranial pressure over time, and everything. And also, regarding a disease-specific limitation of transcranial Doppler itself, whether it's only accurate to assess changes in intracranial pressure that are essentially related to vasogenic changes, that is, increases or decreases in cerebral blood volume, or whether it's also they are also able to detect changes in intracranial pressure that are caused by other mechanisms in the intracranial space, for example, by changing cerebrospinal fluid circulation, or by changing cerebrovenous blood outflow, or even by changing the volume of the brain parenchyma. So, as we observed in our study assessing patients with hydrocephalus undergoing cerebrospinal fluid circulation increases, we can assume in this case that yes, TCD techniques for non-invasive ICP, they are mostly disease specific, and we rely mostly on vasogenic changes of intracranial pressure, other than the other components. And also regarding the perspectives of non-invasive ICP applications, as we know, there is an intrinsic estimation error for all of the techniques using transcranial Doppler, and from our studies is about 10 millimeters of mercury confidence interval for prediction. But as we observed as well, TCD, because of the ability of monitoring cerebral blood flow velocity over time, not continuously, but we can perform over a certain period of time, we can detect changes in intracranial pressure over time. And this would be used, for example, in centers wherein invasive ICP isn't feasible, or in clinical conditions which the knowledge of ICP would lead to a better diagnostic treatment, for example, in cardiac arrest or hepatic failure. And also outside the neurocritical care environment, for example, could be a screening tool for emergency settings, ambulatories, operating rooms, medical practice, and all sorts of scenarios. With this, I would like to thank you for your attention, and I will be happy to take questions.
Thank you, Danilo. We are very, very happy. Thank you for your amazing presentation. Gracias a todos. por estar aquí con nosotros. Antes de pasar a las preguntas y comentarios, les recuerdo que este webinario, esta conferencia, está avalada por el Consejo Mexicano de Medicina Crítica para todos aquellos que se hayan conectado por este medio, por la plataforma de Zoom. Quedará registrada su presencia y así como el tiempo de permanencia, y les haremos llegar al correo que registraron una constancia de acreditación por esta conferencia en línea que, como les comento, está avalada por el Consejo Mexicano de Medicina Crítica. Y pues bueno, me gustaría escuchar a nuestros panelistas, al doctor, ya sea al doctor Arnulfo o al doctor Julio, acerca de precisamente esta conferencia, en base sobre todo a la gran experiencia que están teniendo ustedes allá en Guadalajara, que de hecho están corriendo uno o varios estudios relacionados con la detección de hipertensión intracraneal en los pacientes con trauma craneoencefálico. No sé si quisieran comentar o preguntar algo, que seguro para ustedes estos temas los han repasado mucho. Estoy seguro que para ustedes estas fórmulas que nos ha presentado Danilo las han leído una y otra vez ahí en su literatura diaria, ¿no? Adelante, Arnulfo, adelante, Julio, si quisieran hacer algún comentario.
Sí, bueno, no, antes que nada, felicitar al doctor Danilo por su exposición. La verdad es que es impresionante, pues, toda la información que nos presenta, sus estudios que son realmente interesantes de cómo tratar de entender lo que hacemos con el Doppler, ¿no? Creo que ese es el principal objetivo, ¿no? Que tenemos, es saber cómo interpretamos lo que hacemos, que es el reto que tenemos todos los días con nuestros pacientes. La verdad es que nosotros que utilizamos el ultrasonido como una herramienta cotidiana en la unidad, nos damos o hemos percibido que es una herramienta indispensable para el monitoreo continuo del paciente. Y yo creo que aquí una parte muy importante que ya comentó él es que no son números aislados, necesitamos hacer un seguimiento del paciente y eso es muy importante siempre considerarlo. Yo creo que una medición no hace que hagamos una intervención, sobre todo porque existen muchos elementos alrededor de las mediciones que generan cambios en las mediciones que hacemos, llámense el uso de medicamentos, que por ahí creo que también lo mencionó, el uso de fármacos, aminas vasoactivas, la misma posición del paciente, niveles de CO2, hemoglobina, todo eso afecta los valores que obtenemos de velocidades. Lo que tratamos de hacer con el equipo es traducir presión con medidas de flujo, lo cual a veces no pareciera tener una concordancia. Sin embargo, como ya no lo mostró él, bueno, existen evidencias de que esto nos es útil. Lo más importante para quienes tenemos pacientes monitoreados con Doppler y no tenemos catéteres de presión intracraneal, que es la realidad, creo que de la mayoría en nuestro país y muchas áreas de Latinoamérica, pues tener una herramienta que te permita conocer una tendencia en la evolución del paciente ayuda. No importa quizás el método que uno utilice para calcular, podemos hacer los 4 en cada paciente. Lo más importante es saber cómo está en la mañana, cómo está en la tarde, y una parte a considerar muy importante es la evaluación clínica. El cambio clínico en el paciente asociado a cambios en tu ultrasonido y tu monitoreo, quizás aunado a estas mediciones, sea lo que determine tomar una decisión. Quizás un neurocirujano no vaya a llevar un paciente a quirófano por solo el hallazgo del Doppler. Sin embargo, a nosotros nos permite tener, o quizás decidir llevar un paciente a imagen para que con esto podamos correlacionar y entonces sí se decida si el paciente requiere alguna intervención. Creo que es la parte más importante. No sé qué opinas, Arnulfo.
Bueno, muchas gracias al doctor por su brillante exposición. Y pues sí, bien es cierto, tenemos algo de experiencia en utilizar esta herramienta, lamentablemente, como lo dijo, sin el monitor de presión intracraneal, ¿no? Que es una de las debilidades que tenemos. En ese respecto, doctor Danilo, ¿qué tanto lo recomienda en este momento con el tipo de máquinas que hay disponibles? Que sabemos está el Doppler transcraneal y el codificado en color. ¿Qué tanto recomienda hacerlo de manera ultra temprana, desde la ambulancia o desde que el paciente llega, incluso antes de que se le haga una tomografía? ¿Qué tanto se recomienda para estos escenarios en donde sabemos que el paciente no va a tener acceso a un catéter de presión intracraneal?
Well, basically in these cases, we have had experiences even we published a case report of a patient that had coagulopathy, and in this patient we couldn't do the invasive standard monitoring of intracranial pressure. So in this patient, we followed him for 3 days doing daily assessments of transcranial Doppler ultrasonography, mostly recordings over time. In that case, we did not use the transcranial color Doppler, that because we wanted also not only look at the specific values of mean cerebral blood flow velocity, the pulsatility index, but we also wanted to observe the changes over time in non-invasive intracranial pressure. And then we were able to manage this patient only looking at the temporal changes over time.
Ok. ¿Algún otro comentario, Julio, acerca de, pues, sobre todo la experiencia tan amplia que han tenido ustedes en su unidad respecto a las fórmulas que el doctor presenta de evaluación de la presión intracraneal, los coeficientes de correlación, todo esto que, pues, que muchas veces quisiéramos tener una fórmula que nos estableciera con mucha certeza o mucha correlación la presión intracraneal? Nos gustaría una fórmula en la cual nosotros pudiéramos evaluar en forma numérica la presión intracraneal de forma no invasiva, pero parece que todavía no alcanzamos ese ideal. Pero vaya, ustedes allá en Guadalajara, ¿qué están haciendo respecto a cómo, a la forma en la que ustedes están monitoreando? ¿Qué sí toman en cuenta? ¿Qué no toman en cuenta? Me gustaría escuchar tanto al doctor Arnulfo como al doctor Julio.
Bueno, yo te comentaría un par de detalles, creo que es importantes del Doppler antes de pasar a la parte de lo que usamos nosotros.
Sí.
Yo creo que la parte más importante es que el resultado que obtenemos también, insisto, lo evaluamos a la luz de lo que tenemos en el paciente. Y una cosa que el Doppler tiene es que hacemos medidas globales. Ya lo comentaba el doctor Danilo. De hecho, ellos en su protocolo, el doctor Danilo, lo que hacen es sumar, si no me equivoco, y según entiendo, sus velocidades medias de ambas arterias cerebrales. Y de ahí tenemos el promedio y entonces hacemos las mediciones. El problema del paciente, sobre todo el paciente con trauma, es que debemos entender también que los incrementos en la presión intracraneal pueden deberse a zonas regionalizadas. Y de tal manera que nosotros, yo lo que procuro hacer, por lo menos en mi caso, es hacer una evaluación de un Doppler completo, donde no solamente evalúo arterias cerebrales medias, sino además evaluar arterias cerebrales posteriores, anteriores, el nivel de bifurcación de la cerebral media con la anterior e incluso las arterias vertebrales y basilar. Eso te da una idea un poco más acerca de la situación global del paciente regionalizada. Yo creo que esa es una parte interesante. Desafortunadamente, todos los estudios que hay se hacen basados en cerebral media, porque es la más fácil de insonar, la más grande, la que lleva más flujo, pero cuando hacemos esto de manera cotidiana y estudios completos, te permite incluso regionalizar lo que está sucediendo en alguna zona del cerebro. Creo que esa parte también es muy interesante. Y no sé si quisiera comentar lo de las fórmulas, creo que es quien está llevando más sobre todo de cerca este protocolo de lo que usamos en el...
Yes, I completely agree with Dr. Mijangos. A complete assessment of all the arteries in the circle of Willis is essential. And also not only looking at the arterial vessels, but also in the venous vessels, for example, at the straight sinus, also related to increases in intracranial pressure. And yes, for example, all of these methods, they have been developed based on the assessment of middle cerebral artery. But yes, a more comprehensive approach would be taking more than one assessment. For example, the middle cerebral artery integrated, for example, with a monitoring of the posterior cerebral artery, and observe whether this model would perform more reliably concerning changes in intracranial pressure. But yeah, again, it's in this case would also would consider limitation of the current transcranial Doppler devices, that do not allow multiple insonations at the same time. Some of the more advanced current machines, they will allow that, but they are at the moment very expensive.
Ok, Danilo. Arnulfo, ¿querías comentar algo más? Sobre todo la parte de cuál ha sido tu experiencia correlacionando estos tipos de fórmulas que el doctor propone. Creo que muchas de ellas tú las has utilizado o allá en Guadalajara las han utilizado. ¿Tú qué has visto? ¿Tienen o no correlación cuando tienen la oportunidad de compararla con el gold standard? ¿Cuál ha sido? ¿Ha sido frustrante o no? Al contrario, ¿te has dado cuenta que verdaderamente hay una correlación, quizás más de la que se describe? ¿Qué nos pudieras comentar, Arnulfo?
Sí, en nuestra experiencia pues es bastante útil, sobre todo lamentablemente cuando el paciente está más catastrófico, ¿no? Tenemos muchos casos de muerte encefálica, entonces sin duda nos damos cuenta de que el paciente está ya fuera de tratamiento, ¿no? Pero algo que también es importante es evaluar al paciente primero, lo primero, ¿no? Que es la parte hemodinámica. Muchos pacientes que tenemos, llegamos a ver estudios de Doppler transcráneo anormales, pero la causa es el estado de choque, ¿no? Que es muy común en el paciente con trauma, por ejemplo. Y pues primero es resolver esa cuestión, ¿no? Actualmente yo no recomiendo hacer un Doppler transcráneo si el paciente está con una TA media de menor de 60, ¿no? Por ejemplo. El Doppler es anormal, entonces sí vemos mucho la influencia de la presión arterial. Incluirla en este tipo de fórmulas para mí es esencial, ¿no? Sobre todo la de la velocidad diastólica, que es muy sencilla de hacer, toma en cuenta la tensión arterial del paciente y no así pues el índice de pulsatilidad, que también hemos visto menos éxito para predecir cómo está el paciente. Y pues eso es lo que yo les recomiendo, no evaluar pacientes que están severamente chocados, ¿no?
Claro, y al mismo tiempo quizás esta limitación se pueda convertir en una utilidad cuando estamos reanimando al paciente inestable. Quizás el voltear a ver la circulación cerebral y de alguna manera ajustar nuestro manejo hemodinámico pudiera ser útil. I don't know, Danilo, if you want to comment something else, because we are commenting about the possibility to combine the hemodynamic parameters with the transcranial Doppler in order to achieve certain goals of flow, for instance. Actually, there are some papers about it. I don't know if you want to comment something about it.
Yes, well, regarding the multiple approach using not only one parameter obtained with transcranial Doppler ultrasonography, we have also, with Dr. Chiararaba, we have published the assessment of optical optic nerve shift diameter combined with venous transcranial Doppler ultrasonography from the straight sinus. And in this, at this study, we have assessed different combinations for this multiple approach in trying to obtain a more reliable method. We took several components of the cerebral blood flow velocity waveform, trying to see whether it would improve the linear model between changes in ICP and changes in optic nerve shift diameter and the venous or arterial transcranial Doppler values. So it turns out that for traumatic brain injury patients, the systolic peak of the venous circulation in the straight sinus, it's not properly a systolic peak, but for patients, for TBI patients in whom we observe increase in intracranial pressure, we see that the venous circulation, it will present something translatable to a systolic peak. That call it peak, but it itself is not a peak. So we extract that value from the waveform, and combined with the optic nerve shift diameter, we can obtain a more reliable model to estimate intracranial pressure non-invasively.
Right, okay, thank you, Danilo. Doctor Mijangos, no sé, en base a ahora comentando respecto a la enseñanza del Doppler transcranial y esta parte que creo que carecemos todavía en cuanto a en el tema del entrenamiento a los médicos intensivistas, creo que todavía no es tan sencillo tener acceso a un entrenamiento formal de Doppler transcranial como se tiene en otras áreas, ¿no? Donde hay cursos de reanimación, hay cursos de eco pulmonar, hay ecocardiografía básica y avanzada, pero la parte del entrenamiento del médico intensivista, quizás enfocado a detectar los tres, digamos, ejes del eco transcraneal, que es detección del vasoespasmo, la muerte cerebral y la detección de hipertensión intracraneal. Doctor Mijangos, ¿qué opina respecto a este tema, el entrenamiento de los médicos intensivistas, ya que ustedes, y particularmente usted, doctor Mijangos, pues ha desarrollado mucho la parte de la enseñanza, pero solamente ahí en el centro que es Guadalajara? Pero ¿qué nos puede opinar acerca de esto, doctor Mijangos?
Bueno, la realidad es que en el mundo, yo diría que hace 10 años comenzó a haber un poco más de cursos para la capacitación del Doppler, pero están enfocados más a la parte técnica. Ya, sobre todo en Estados Unidos, de hecho ellos tuvieron que traer personas de Rusia y, bueno, otras partes del mundo para poder llevar a cabo la capacitación. Y ahora, bueno, ya con los centros de stroke, creo que eso se ha globalizado un poco más. En México, desafortunadamente, no tenemos todavía un área, vamos, de certificación oficial. Y si comparamos con Estados Unidos, te piden que realices cerca de 100 estudios más o menos supervisados para que te consideren capacitado. Pues obviamente nosotros en el servicio, los residentes de formación, pues hacen todos los días Doppler, ¿no? Entonces ellos sin problema o desarrollan las habilidades. Hemos trabajado con varios cursos de capacitación, pero desafortunadamente el otro problema que nos enfrentamos es la disponibilidad de equipos, que si bien es cierto, yo creo que más recientemente se disponen de equipos tanto duplex color como Doppler pulsados, pues eso es una herramienta que nos ha sido, digamos, todavía nos ha limitado pues la disponibilidad para que la gente se capacite y obviamente tenga un buen entrenamiento. De hecho, estamos trabajando ahí cerca de unas 40 personas más o menos que estamos trabajando en la formación de un grupo para la capacitación de ultrasonografía de cráneo, sobre todo con el Doppler pulsado. Y hemos empezado con una labor también a través del IMSS y se hizo el intento para hacer una especie de capacitación a intensivistas para sobre todo la parte de arresto cerebral que lo hicimos el año pasado, hace 2 años aquí en Guadalajara. Yo creo que tenemos que trabajar en eso, creo que en eso, bueno, todo el grupo que ustedes encabezan con la parte de AMUSCU, si bien no todo es, no solo es Doppler transcranial, sino que se abarcan pues toda la parte de ultrasonografía en el paciente crítico. Yo creo que sí es una herramienta que tenemos que seguir impulsando, desarrollando, porque bueno, en el momento en que uno la tiene, se da uno cuenta que es útil, ¿no? que se necesita, pero sí creo que tenemos que trabajar por un proceso de estandarización del procedimiento, porque si no lo hacemos, corremos el riesgo de interpretar cosas que no son las correctas. Entonces, si bien hay muchos sesgos dentro del uso de ultrasonografía para poder interpretar, como en el caso de hipertensión intracraneal, pues el más importante es que no lo hagamos bien. Y en eso debemos estar seguros que quien realiza el estudio esté lo suficientemente capacitado. Yo creo que esto es lo que viene para nosotros como parte del trabajo que hay que desarrollar, pero pues creo que hay bastante gente entusiasta que nos va a ayudar en eso, ¿no? Y en eso los cuento a ustedes, ¿no?
Claro, sí, Arnulfo, no sé si tú quisieras también agregar algo de lo que tú quisieras agregar, ¿no?
Pues preguntarle al doctor Danilo cómo es el proceso en su hospital o en Cambridge, ¿no? Que es una gran escuela de Doppler transcráneo, en cuanto a al entrenamiento, ¿no? A la curva de aprendizaje de quienes realizan el ultrasonido, el Doppler transcranial.
Yeah, so regarding training to the ICU physicians, Dr. Chiara, she has been one of the major enthusiasts in training back there, when she was when she was a consultant in the neurocritical care sciences unit. So during her stay there, we had 2 of the sonic courses, so sonography in neuro intensive care. And so now this course has been also, well, people around Europe are also doing the same type of trainings. For example, in 2018, I was also invited to come to Italy in Brescia, where they also performed the same type of course in neurosonology, and some of the major conferences in neurocritical care. They are also inviting people to give these courses, just to engage more people in transcranial Doppler ultrasonography, because it's such a powerful tool in the daily assessment of these neurocritical care patients.
Claro, yes, Danilo, it's very, very interesting, all the work you have been doing in Europe and in other parts of the world.
Yes.
Actually, we are very, very enthusiastic for doing that course in Mexico. We would like to invite you in the next year, hopefully. Bueno, no sé, doctor Arnulfo, doctor Mijangos, sí, bueno, pues para concluir y no sé si quisieran comentar algo más. Sé que, bueno, pues hay muchas otras preguntas que, sobre todo ustedes que han estado desarrollando más esta área y con todos estos estudios que van a ustedes a proyectar en los próximos meses que están realizando. No sé, doctor Mijangos, si quisiera comentar algo más.
Sí, fíjate que algo que sí creo que es importante comentar para quienes están haciendo ya Doppler actualmente en sus unidades. Hay que recordar también que la edad del paciente cuenta para lo que obtiene. Si el paciente tiene aterosclerosis, por ejemplo, uno puede tener mediciones también de índice de pulsatilidad distintas. Y si no tenemos un estudio previo del paciente, como es lo común, que no tenemos un estudio previo a que llegue a la terapia, a veces podemos también interpretar cosas que no son correctas, ¿no? Entonces, en pacientes mayores, sí es una parte a veces compleja de querer interpretar, ¿no? Entonces, como bien decía el doctor Danilo, hay muchos elementos alrededor del estudio que todavía nos limitan. Pero, insisto, es una herramienta útil, sobre todo cuando lo utilizamos en un monitoreo continuo, ¿no? Y agradecido nada más con la invitación.
Perfecto, doctor. Arnulfo, no sé si quieras algún comentario final para el doctor Danilo, para nuestra audiencia que nos está escuchando en este momento.
Muchas gracias al doctor Danilo, pues gracias por su tiempo, gracias por su colaboración y por su excelente presentación, y pues me gustaría seguir con el vínculo, ¿no? Para futuras experiencias de educación y de investigación, porque también pues, es importante seguir buscando más información acerca de la utilidad del Doppler transcranial.
It would be my absolute pleasure.
Thank you, Dr. Danilo. We were very, very happy and excited for having you.
I'm happy too.
Thank you so much, Dr. Danilo. Well, I'm going to finish the webinar. Voy a agradecerles a todos los que estuvieron con nosotros, tanto en nuestra página de Facebook, como les recuerdo, este webinario estuvo avalado por el Consejo Mexicano de Medicina Crítica. Les haremos llegar una constancia a todos los que se conectaron a través de la plataforma. Invitarlos el próximo año a asistir a nuestros cursos y actividades que tendremos, una gran agenda para el próximo año, invitarlos a participar. Seguramente tendremos por ahí algunas sorpresas relacionadas con este tema específico. Y pues bueno, por nuestra parte ha sido todo. Le agradezco al doctor Mijangos por prestarnos su tiempo también para compartir este espacio. Teníamos ya desde hace tiempo, doctor Mijangos, las ganas de compartir este tópico con usted, y de verdad que estamos muy agradecidos, sobre todo por la gran labor que está haciendo con nuestros compañeros allá en Guadalajara, y al doctor Arnulfo también por todo ese entusiasmo que ha presentado durante todos estos últimos años enseñando y difundiendo esta noble herramienta. Thank you so much, Dr. Danilo. I don't know if you want to say something to our audience, your last words to our
Latin American audience. to appreciate the invitation. It was a great pleasure for me to present some of my works developed during the PhD. And I'm really open to future collaborations, and let's keep the transcranial Doppler community active and try to elucidate the many questions that we have too.
Thank you so much. I'm going to finish the webinar. Gracias a todos por su participación y pues bueno, los estaremos esperando en otras de nuestras actividades. Thank you so much, Dr. Danilo. Gracias, Arnulfo. Thank you, Dr. Mijangus, for participating.
Gracias.
Thank you so much. See you later. Bye. Thank you so much,
Bye.
Dr. Danilo. Bye.
Bye-bye.
Bye-bye.